Today we have Dr. Cessal Thommachan Kainickal. Sir is additional professor, head and neck oncology, RCC Trivandrum. Welcome, sir. Very good evening. Today topic of discussion induction chemotherapy in locally advanced head and neck cancer, squamous cell carcinoma, hope or high. So welcome, sir, and welcome to everyone. Sir, over to you.
Thank you very much for the invitation. Can you stop sharing the screen?
Yes, yes, sir.
Thank you. So, thank you. So, can you see my slides?
Yes, sir. Yes, sir.
Okay. Yeah, thank you very much for your. Yeah. So, you want me to wait for a few more minutes, or you want me to start?
We can wait a few minutes more so that more participants can join.
Yeah, sure. Okay. Please let me know. Okay. Yeah. Okay. We will start. No issues. Okay. We'll start because I want the people to be from the beginning. Okay. Otherwise.
Yeah. Yes, sir. I think we can start now.
Okay. Thank you.
Thank
Okay.
you.
So today I will be discussing about the role of induction chemotherapy in locally advanced head and neck squamous cell carcinoma. So we know that the locally advanced head and neck cancers, most of the patients in head and neck cancers present at an advanced disease, and 50 to 60% present at stage 3 or stage 4 disease. The main intention of treatment is to have a good locoregional control because the head and neck squamous cell carcinoma is presumed to be a locoregional disease. So we believe that if you can attain a good locoregional control, this will be translated into a better disease-free survival as well as overall survival. So when we look into the treatment, the options for locally advanced head and neck squamous cell carcinoma, it is either radiotherapy plus systemic agent or you do surgery followed by postoperative radiotherapy. In all patients who are candidates for surgery, the patient should have a planned postoperative treatment, either adjuvant radiotherapy or adjuvant chemoradiation in high-risk patients. So that is the backbone of the treatment of locally advanced squamous cell carcinoma. So if you look into the McKenzie meta-analysis that was published in 2009, you can see that in stage 1 and stage 2 patients, and there is no role for any systemic agent. So if you look into a locoregional treatment plus chemotherapy, in stage 1 and stage 2, there is no disease. That is the reason why we say that in stage 1 and stage 2 disease, the treatment is only either radiotherapy or surgery. It is a single modality treatment. Then the magnitude of benefit is mainly seen in stage 3 and stage 4 patients. And the magnitude of benefit was more pronounced in stage 4 patients compared to stage 3 patients. So this was the data in 2009. We have an update of this, and I will be discussing the due course. Okay, so in stage 3 and stage 4 disease, so this is constitute the curable locally advanced disease. That is, stage 3 means T3 disease or N1. Stage 4A means T4A or N2 disease. So this is stage 3 and stage 4A. Treatment is radical approach. This is applicable for patients up to 70 years in patients who have performance status 1. So beyond that, majority of the patients should be individualized. The treatment should be individualized. Patients who have performance status or elderly patients should be treated in an individualized approach. In patients who have T4B disease or N3 disease, always this should be individualized because this is an advanced primary and this is an advanced nodal disease, especially in N3B disease. This is stage 4B disease. In all sites like oral cavity, oropharynx, larynx, and hypopharynx, this has to be individualized in patients who have T4B or N3 disease. Metastatic disease at presentation is very low in head and neck cancers compared to other. So this is very constant, very small percentage. So two treatment approaches: one, radiotherapy plus systemic agents, or you do surgery plus adjuvant treatment based on the HPR. So all patients who are planned for surgery should have enough reserve to undergo the planned postoperative radiotherapy. Now, whether can you say that surgery is superior to radiotherapy or chemoradiation? Surgery followed by radiotherapy is superior to chemoradiation, or radiation or chemoradiation should be given only to patients who are not suitable surgery? So this question was asked by Singapore group from the National Cancer Center Singapore, and they have done a clinical trial comparing surgery plus adjuvant radiotherapy versus concurrent chemoradiotherapy in stage 3 and stage 4 non-metastatic squamous cell carcinoma. So this was a randomized trial comparing these two approaches, and the disease-free survival and overall survival showed there is no difference in the outcome, which was published in British Journal of Cancer in 2005. The conclusion is that you cannot categorically say that surgery followed by radiotherapy is superior to chemoradiation, or chemoradiation is superior to surgery followed by postoperative radiotherapy. But in general, it is presumed that oropharyngeal carcinoma, larynx, and hypopharynx with cartilage intact, and patients who have say a selected gingivobuccal complex tumor are treated by a non-surgical approach, that is chemoradiation, and patients who have tongue tumors, patients who have gingivobuccal complex tumors with a bony involvement, patients who have larynx or hypopharynx with a cartilage is involved or a dysfunctional larynx, generally they are treated by surgery followed by postoperative radiotherapy. So this is the approach in patients who have locally advanced disease. So this we have already discussed. So this also I have told you: oropharyngeal carcinoma, larynx or hypopharynx with intact cartilage, and advanced gingivobuccal complex tumors without a bony involvement or a skin involvement. These are the patients treated with chemoradiation. So if you have a patient who is a 58-year-old gentleman who is a smoker and alcoholic, presents with a locally advanced disease in the oropharynx. Say this is a lesion involving at the level of the tonsil. So you can see that the left lateral pharyngeal wall, the lesion is involving the left lateral pharyngeal wall, involving the tonsillar fossa, involving the base of tongue, posterior pharyngeal wall, and maybe a slight closely abutting the carotid sheath. And also the lesion is involving up to the retromolar trigone, abutting the medial pterygoid muscle. And it was a T3 disease, and the patient who had two nodes. So the left level 2 nodes. So this is a submandibular gland. So posterior to that, you have a level 2 node, and also another lesion behind the internal jugular vein. So this is a 2-way node, and this is a 2B node. So this is the line of demarcation between the 2B and 2B. That is the posterior edge of the internal jugular vein. Surgically, it is the spinal axis. So it is a patient is having 2A and 2B lymph node and an advanced primary of the oropharynx. And patient is having a performance status 1, good renal parameters, and what should be the treatment for this patient? Whether this patient should be offered concurrent chemoradiation, so whether this patient should be offered induction chemo followed by chemoradiation, or you have to give induction chemo followed by radiotherapy, induction chemo followed by cetuximab plus radiotherapy, or you should give concurrent chemoradiation plus a monoclonal antibody. So can you chat in the chat box? So how will you treat this patient? So you will come across a few clinical problems like this in today's lecture. So 58-year-old gentleman, PS1, CA-T3 and 2B disease. And how will you treat the patient? So concurrent chemoradiation, induction chemo followed by chemoradiation. So what should be the approach? Can you Can you post in the chat box? Okay, no one is interested to answer. Okay. Okay, no response. Okay, so anyway, I will proceed further. Okay, there is one response. Yes, setting is different. Okay, so can you set? Yeah, okay. So I think can you enable the this participants to Jaiswal? Can you enable the participants to type? Yeah, sorry, the setting was different. Okay, yes. Can you enable them to chat? Yes, I think I can also do that. Security. Yeah, yeah. Okay, so many are saying it is concurrent chemo radiation. Okay, so many say that is concurrent chemo. So we will go to that. Okay, so that's right. So there are two components in concurrent chemo radiation, and this is the radiotherapy. Radiotherapy, it forms the main dish. Okay, main dish, and a high quality uninterrupted radiotherapy forms the backbone of a locally advanced disease like that oropharyngeal carcinoma with a dessert that is the systemic agent. So how to incorporate this dessert along with this main meal or before the main meal as a starter or after the meal. So that will be the discussion today. Okay, what is the evidence for the situation? Okay, now we come to the next. Okay. So what are the advantages and disadvantages of incorporating systemic agent before, along, and so in different ways? Suppose if you give chemo before the definitive radiotherapy and no chemo along with radiation, that may be the least toxic way. So you give chemo, then you assess the response. So this may be useful for an organ preservation approach like VA trial, the EORTC trial for hypopharyngeal tumors. So that we will take up. So this is you give induction chemo, assess the response. If there is response, then you consider them for an organ preservation approach. Second is a reduction in distant metastasis. That is another concept. You give induction chemo before the definitive radiotherapy, and it is least toxic. What is the problem? When you give induction chemo followed by radiotherapy versus radiotherapy alone, there is an increased treatment time. Okay, a substantial number of there is an actual repopulation, and the patients may be receiving a radio-resistant clone radiotherapy, the definitive treatment. And there is lack of a local synergy between the two treatment modalities. When you give concurrent chemoradiation, there is synergy, shorter treatment time, but there is no reduction in distant metastasis. The sequential chemoradiation means you give induction chemotherapy first, then you give concurrent chemoradiation. The rationale is that induction chemotherapy will take care of the distant metastasis, and the concurrent part will take care of the enhancement of radiation. But the concern is that it is with a lot of toxicity and increased treatment time. Sometimes a substantial number of patients may not be able to complete the definitive treatment, radiotherapy or chemoradiation, if you give induction chemotherapy before that. So these are all concerns. So what is the evidence? Okay, we look into the McKenzie meta-analysis, which was published in 2000. It has showed that if you give concomitant, that is radiation and chemotherapy together, compared to radiation alone, there was a 8% benefit at 5 years. And this is quite statistically significant. When you give neoadjuvant chemotherapy before radiotherapy compared to radiotherapy alone, it shows that the benefit is at 2%. But this was not statistically significant. Okay, the p-value was not significant. But when you give adjuvant treatment, it again, there was no benefit, but it showed only 1% benefit. That was in 2000. Now, when they updated, there was an update for the McKenzie meta-analysis, which was published in 2007. Then in 2009, they updated. And very recently, they have come up with an update that published in Green Journal in March 2021, and that's this year. The primary endpoint was overall survival. It included around 19,000 patients from 107 randomized clinical trials. Primary endpoint was overall survival. The secondary endpoints were event-free survival, locoregional failure, the 120-day mortality, distant failure, and cancer, that is a head and neck mortality and non-head and neck cancer mortality. So this was the main design of the meta-analysis, was to know the locoregional treatment versus locoregional treatment plus chemotherapy. And the second aim was to compare the concurrent basis induction chemotherapy. These are the two aims of the meta-analysis. So when you look into the concomitant, that is locoregional treatment basis, that is patients who receive radiation in the definitive treatment or post-operative radiotherapy, that basis, if you add chemotherapy along with definitive radiotherapy or post-op radiotherapy, then concomitant, it was 10,000 patients, the median follow-up of 9.2 years, there was an absolute benefit of 6.5% at 5 years and 3.6% at 10 years. And event-free survival was also better in patients who received concomitant basis locoregional treatment alone. There was no increase in 120-day mortality. There was a reduction in the local recurrence, that is locoregional failure. There was a reduction in locoregional failure, and there was no difference in distant metastasis. There is a benefit in, or there is a decrease in head and neck cancer death. So this was a conclusion when a treatment was offered, chemotherapy along with radiation, along with locoregional treatment, and the chemotherapy was added concomitant. Okay. Now, when we look into the induction chemotherapy, the median follow-up was 5.7 years. The hazard ratio of death was 0.96. In the hazard ratio in the other, it was 8.81, and this was not significant. There was no difference between the regimes. So either used EPF or PF. Compared to the locoregional treatment, there was no difference. The head and neck mortality was not reduced, and there is known cancer death was also, there is no difference. So the conclusion is that there is no difference in overall survival, there is no difference in locoregional failure or event-free survival, but there was a significant decrease in distant failure, and this was statistically significant. And the patients who received induction chemotherapy versus locoregional treatment, those patients who had poor performance status, was associated with a poor overall survival, and this was also statistically significant. Then that was the conclusion from the concomitant basis locoregional treatment and the induction chemo basis locoregional treatment alone. Now the adjuvant chemotherapy, that was in almost 3,000 patients, and the hazard ratio of death was 1.02, means it is a negative impact, and this was not statistically significant, but there was a event-free survival, hazard ratio was 0.8, there is a minus 0.6% benefit, it's a minus 0.3, and there is a 120-day mortality was high, and this is quite statistically significant. Hazard ratio is 1.89. What does it mean? It means it is having a negative impact. The 120 mortality was high, the event-free survival and hazard ratio of death was also minus, means it is not having an impact on the outcome. Comparing concomitant and induction, there was a direct comparison and there was an indirect comparison. I will be discussing only the direct comparison. At a median follow-up of 9 years, it was found that the benefit was mainly for patients who received concomitant basis induction chemotherapy in terms of overall survival, event-free survival, or locoregional failure. It means all were statistically significant. In the overall survival, the absolute benefit was 6.2% at 5 years, and event-free survival, it was 3.7% at 5 years, and locoregional failure, it was 5.8% at 5 years. So all were statistically significant. So what does it mean? It means the concomitant is better compared to induction. Now, next question. Okay. So what is the role of TPF in locoregionally advanced head and neck squamous cell carcinoma? So incorporating a cisplatin 5-fluorouracil and docetaxel. So the induction benefit was seen in a subset analysis of the McKenzie. It was published in Annals of Oncology in 2002, and it was showed that those patients who received induction chemotherapy, there was no benefit. It was only 2% that I have shown you. So that was only 2%. But when they dissected the various induction chemotherapy regimes, it was found that those patients who received cisplatin 5-fluorouracil, the difference was 5%. And this was borderline statistical significance. The p-value was 0.05. So can we incorporate a third drug in addition to the two drugs. So this can be improved further by adding another drug to the PF. So then there are two generation of clinical trials were initiated. The first generation of clinical trial was to know that which is the best induction chemotherapy. That is, you give cisplatin 5-fluorouracil as induction chemotherapy followed by radiotherapy, or you give 3-drug induction chemotherapy followed by radiotherapy or chemoradiotherapy. Okay, so this was 2-drug versus 3-drug. So there are 3 major clinical trials were evaluating the role like this, and there was no concurrent chemoradiation arm. This was mainly to know which is the best induction chemotherapy, and it is not to know which is the standard approach. And the second approach was to compare the standard chemoradiation versus 3-drug induction chemotherapy with the 3-drug followed by the standard chemoradiation to know which is the best way in locally advanced head and neck squamous cell carcinoma. So the one arm, the control arm was the concurrent chemoradiation. Experiment arm was 3-drug induction chemotherapy, that is cisplatin 5-fluorouracil and a taxane, followed by the same concurrent chemoradiation. So then I will discuss the first approach first. This includes 3 trials. That is the TAX323 clinical trial that was done by the URTC group, 24971 clinical trial. The Thommachan was the principal investigator for that. It was presented in ASCO annual meeting in 2004, published in New England Journal of Medicine in 2007. TAX324, same. This is a European trial, and this TAX324 was an American trial by Marshall S. Posner, same published in 2007, same edition of New England Journal of Medicine 2007. The data was published with a 3-year efficacy results were published. So there was a slight difference between the 2 trials. In the TAX323, the dose of the 3-drug, the cisplatin 5-fluorouracil dose was same in both trials. The dose was different in TAX323. It was 75, 75, and 75. The cisplatin was 75, docetaxel was 75 mg per meter square day 1, and cisplatin day 1, 75 mg per meter square, and the 5-fluorouracil was 75 mg per meter square day 1 to day 5 as a 24-hour infusion. The TAX324 used a slightly higher dose. That is, the docetaxel dose was the same, but the cisplatin dose was 100 mg per meter square, and the 5-fluorouracil was 1 gram per meter square, is in day 1 to day 5. And the second difference was the TAX323 used after the induction used only radiotherapy and did not have after induction chemotherapy only radiation was given. So 2-drug 5 versus 3-drug followed by radiotherapy for both. But in the TAX324, it used carboplatin as AUC 1.5, weekly carboplatin was used. Another third trial was a matrix study that by the HIT et al. So that I will discuss later. So first I will discuss the TAX323 and 324. Initially, it was both published in New England Journal of Medicine in 2007. And there was a 5-year update for the TAX324, and that was published in Lancet Oncology in 2011. So it was shown that both the trials, the 3-year efficacy of the Thommachan trial and the Marshall S. Posner trial, that is 2011 update, that is a 5-year update, both showed that there is an improvement in the primary endpoint was progression-free survival in the European trial, whereas overall survival in the American trial, and showed that both the primary endpoints were better in patients who received 3-drug versus 2-drug. So that was the conclusion of the 2 trials. And the third trial was the HIT trial that was published, that is from the Spanish head and neck group, and this was published in JCO in 2005. And the similar design, but the chemotherapy they used cisplatin, 5-fluorouracil, and the paclitaxel instead of docetaxel. There's a 3-arm of cisplatin, 5-fluorouracil, paclitaxel basis the 3 cycles basis the cisplatin 5-fluorouracil. When they evaluate the results in terms of overall survival for all patients comparing induction 2-drug versus induction 3-drug, it was found that there was a trend towards improvement in overall survival, but this was not statistically significant. But in unresectable disease, the survival was the point is missing there. So it is a 0.046. It was significant. So conclusion from these three trials was that all the 3 trials showed efficacy in terms of their primary endpoints, but there was an increase in toxicity. The growth factors were the optional for these trials. And so to know which is the best approach in 2-drug versus 3-drugs, the same group, the McKinsey, the meta-analysis of chemotherapy in head and neck cancer group, that's McKinsey group, done an individual patient data meta-analysis, which was published in JCO in 2013. And this with a very good editorial by Arlen Forrester, which was a PI of the RTOG 91115. And so this was a comparing 2-drug versus 3-drug, and very good editorial. So editorial shows induction chemotherapy meta-analysis in head and neck cancer. Right answer, wrong question because no concurrent chemo radiation. But the right answer because 3-drug versus 2-drug, 3-drug is better in terms of overall survival and progression-free survival at 5 years. At 5 years, in terms of overall survival, there was a 7.4% improvement. That is 35% for the 2-drug versus 3-drug was 42.4%. There is a 7.4% improvement in survival. Then the second was the progression-free survival. There was a 7.1% improvement, 28.4 versus 35.5. There was an improvement in progression-free survival as well. But the billion-dollar question is that what is the role of induction chemotherapy in the era of concurrent chemoradiation? So that is CCRT, that is concurrent chemoradiation versus 3-drug induction chemotherapy followed by concurrent chemoradiation. So in the era of concurrent chemoradiation, what is the role of the 3-drug induction chemotherapy? This question was evaluated in 3 clinical trials. That is one by the trials where say to know which is the best approach in locally advanced small cell carcinoma. Then the control arm was concurrent chemoradiation. The one is by the DECIDE, that is from the Europe. That is the DECIDE trial, which was published in JCO in 2014 by Cohen et al. And this was only patients where N2 or N3 patients were included because these patients are likely to have high chance for distant failure. So whether induction chemotherapy has a role in reducing distant metastasis, that was the main objective of this trial. And this was also associated with a good editorial by Never Ending Story. And then if you look into the results, there is no difference in outcomes. Recurrent-free survival, distant failure-free survival, and the overall survival all were not significant. Means there is no point in giving a 3-drug induction chemotherapy compared to concurrent chemoradiation alone. Now the same question was asked by the again this is another approach, a paradigm trial. This was published in Lancet Oncology in 2013. It also showed there is no benefit either in terms of overall survival or progression-free survival. The third approach from the Spanish head and neck group. This is a 3-arm clinical trial. The first time was the concurrent chemoradiation. The second arm was 3 cycles of PF followed by chemoradiation. Or the third arm was you give TPF followed by chemoradiation. And this paper was presented in the ASCO annual meeting in 2009 in Orlando. And this was published in Annals of Oncology in 2013. And you can see that all the 3 graphs are hugging each other. There is no difference between the outcomes of all 3 modalities. This was followed by a meta-analysis incorporating all the trials which we have discussed. This was published in 2016 in Green Journal after a presentation in ASCO annual meeting in 2014. And again, there is no difference either in terms of progression-free survival or overall survival. There's no difference between the outcomes. So this is again, the main concern is that there is no benefit by adding an induction chemo 3-drug before the standard chemo. Now the 2 approach which mainly from Europe came, one from the Italian group, another is from the French group. So can we give induction chemo followed by cetuximab plus radiotherapy versus the concurrent chemoradiation? Can we attain a better result? And 2 trials, one is by the GOTEC 2007-02 clinical trial, which was published in JCO in 2018 after a presentation in ASCO annual meeting in 2016. And second trial, this is the Italian trial. The Italian trial, this is published last year in Oncology, and 2,078 patients were randomized. Stage 3 and stage 4 patients were randomized either to give concurrent chemoradiation or 3 cycles of TPF followed by radiotherapy plus cetuximab. And the dose of the TPF, which was used similar to that of a TAX324 regime. And the cetuximab used was similar to that of a border trial design. Then, when they published the results in 2020 in oncology, and you can see that the overall survival, there is no difference. So, concurrent chemoradiation is same as induction chemo, 3-drug TPF, followed by 3 cycles, followed by cetuximab plus radiation. In toxicity, there is a slight difference in toxicity. So, those patients who received TPF had a higher neutropenia, and the patients had high skin toxicity. But in patients who received concurrent chemoradiation, had a higher weight loss. So there is a difference in toxicity profile. A similar design was by the French group, that is the GOTAC 2007-02 clinical trial. They used N2 or N3 patients, similar to the DECIDE trial, which we have discussed earlier. The N2 or N3 patients were randomized. So they had a GOTAC 2007-01 clinical trial, which was comparing concurrent chemoradiation basis cetuximab plus radiotherapy. That is for low-risk patients, mainly have small primary, it's heavy, the patients who do not have a bad nodal disease. So here, a heavy nodal disease patients were randomized to give TPF plus cetuximab plus radiation. So 3 cycles of TPF followed by cetuximab plus radiation, or you give radiation, chemoradiation. But they used carboplatin plus 5-fluorouracil along with radiation. When they published the results in JCO in 2018, with a median follow-up of 2.8 years, there was no difference in progression-free survival, overall survival, or local control. There was a borderline significance of a distant metastasis-free survival. This is p-value as 0.05. So in patients who received TPF followed by cetuximab plus radiation compared to concurrent chemoradiation. So I'm coming to the conclusion of what we have discussed so far is induction chemo or neoadjuvant chemo prior to concurrent chemoradiation. There is no proven benefit. So you may give in patients who have, say, N3 node, or patients who have any logistic reasons like a delay in starting treatment, or you feel that this patient may require an adaptive planning if you start chemoradiation directly. So these are all logistic reasons you can give them. Otherwise, there is no evidence. The second is you give induction chemo followed by RT plus cetuximab basis concurrent chemoradiation. Again, there is no benefit. The adjuvant chemotherapy is associated with an increase in and a decrease in overall survival, event-free survival, and there is an increase in 120-day mortality based on the McKenzie meta-analysis. So it is detriment. It should be avoided. And concurrent chemoradiation remains the standard of care. Now, the second role of induction chemotherapy comes from the organ preservation trials. So first we will discuss the larynx, and then we will take the hypopharynx. So if you have this is a T3 because the lesion is a supraglottic larynx. The lesion is involving the pre-epiglottic space. This is an array-epiglottic fold, epiglottis, and the pre-epiglottic space. This is a hyoid bone. So you can see that it's a T3 disease. Okay, this is a pyriform sinus. So you have a supraglottic larynx extending in the pre-epiglottic. This is a normal pre-epiglottic space, hypodense, which is continuing laterally as the paraglottic fat. Normal array-epiglottic fold, normal pyriform fossa. So this is the lesion, so it's a T3 disease, or a patient who have a pre-epiglottic space. So this is also this is again a pre-epiglottic. This is a normal pre-epiglottic space you see in a sagittal view. You can see that the pre-epiglottic space is filled, and there may be a tumor. It is infiltrating and extralaterally anterior. So you can see that this may be a thyroid membrane, maybe pierced. You have to check in the other parts as well. So then you have a T3 larynx, you have a paraglottic fat infiltration from, again, a supraglottic larynx, array-epiglottic fold. And you have a paraglottic fat or inner cortex, this is also T3. And this patient is having a subglottic extension, inner cortex. So these are all T3. So do you need to give induction chemotherapy, or this patient can be offered a concurrent chemoradiation? Again, two schools of thought. Okay, so if you look into the Europeans, they believe mainly in induction, but the Americans believe in concurrent. So if you look into the evolution of the organ preservation in larynx and hypopharynx, you can see that it started with the VA trial that is published in New England Journal of Medicine in 1991, then followed by a concurrent chemoradiation strategy by the RTOG 9111. So before the VA trial, all the T3 and T4 patients but were all undergoing a total laryngectomy followed by adjuvant radiation. So then the first approach was to know whether we can preserve as if you give induction chemotherapy and avoid a laryngectomy. So that was the VA trial. Then say the concurrent chemoradiation trial in the RTOG 9111. So what is the role of concurrent chemoradiation? So that was the RTOG 9111. If you look into the VA trial, I'm sure many of you know this, because the around 332 patients, stage 3 and stage 4 CA larynx patients were randomized to give surgery. This was the control arm. The experimental arm was you give 2 cycles of cisplatin 5-fluorouracil. Those patients who had a partial response were offered 1 more cycle of cisplatin 5-fluorouracil of the waiting period for radiation. Then you give radical radiotherapy. Those patients who did not attain a partial response, that's at least response, with 2 cycles of cisplatin 5-fluorouracil, were offered surgery followed by post-operative radiotherapy. And the pitfall of this trial was the VA trial included T4 patients as well. So T3, T4 patients with the cartilage destruction patients were also included in the trial. So when all patients were put together, it was found that the 2-year laryngeal preservation was 64%. And there is no difference in the outcome between the 2 arms. So the conclusion is that if you give induction chemotherapy, there is a chance for increasing the organ preservation for responders without compromising the overall survival. So that was the conclusion of the VA trial, and this data was published in New England Journal of Medicine with a median follow-up of 33 months. Now, if you look into the various trials, the induction chemotherapy trials incorporating in ATs, this is cisplatin 5-fluorouracil. So if you give, say, 2 to 4 cycles of cisplatin 5-fluorouracil for a locally advanced, newly diagnosed, locally advanced squamous cell carcinoma head and neck, it was found that in 7 trials, it was found that if you give 2 to 4 cycles, at least 30% of the patients will attain complete CR. And partial response CR plus PR, that's around 85%. If you give carboplatin, that number may be slightly inferior, 26%. So that is CR. But if you look into the McKinsey meta-analysis, although there was an improvement in response, and there is increase in organ preservation, but if you look into the local control or survival, there is no difference. So it means it increases response rate and it increases organ preservation, but it will not improve the overall survival. Now, when you look into the concurrent strategy, that is, it is the RTOG 9111. This was a trial, it was a 3-arm clinical trial comparing. So you give either the control arm was the experimental arm of the VA trial. So that is, you give induction and as a response, and then you consider radiation or surgery followed by radiotherapy. The second arm was to give concurrent chemoradiation. Third arm was radiotherapy alone. Initially, the data was published in New England Journal of Medicine in a 3-year follow-up. 3-year efficacy results was published in NEJM in 2003. It showed that local control and the laryngeal preservation was better in patients who received concurrent chemoradiation. The overall survival data was not mature. And the data was updated in ASCO annual meeting in 2006. And later it was published with a 10-year follow-up in 2013 March in GC. When you look into the final results of this trial, there is no difference in survival between the 3 arms. And the laryngeal preservation and local control were better in patients who received concurrent chemoradiation compared to the induction chemo or radiotherapy alone. So local laryngeal preservation and local control were better. The survival, there was no difference, but although there was an insignificant trend towards an poor survival in patients who received concurrent chemoradiation, but this was not statistically significant. There was no difference in distant control between the 3 arms. So the induction chemotherapy did not reduce a reduction in distant metastasis, although there was a trend. So but it was not statistically significant. That is the American approach. So when the VA trial was done, can we improve the efficacy by incorporating a third drug? So that is the GOTAC 2001 clinical trial. So this was you compare cisplatin 5-fluorouracil versus cisplatin 5-fluorouracil plus docetaxel alone for laryngeal preservation. So the larynx and hypopharynx patients were included in the trial. So the patients were PF versus TPF, that is, the number of patients were low, and the patients who responded to the induction chemotherapy were offered radiotherapy, or non-responders were offered surgery followed by postoperative radiotherapy. The primary endpoint of this trial was laryngeal preservation. Secondary endpoints were overall survival, progression-free survival, and the patient in toxicity. And this was presented in ASCO annual meeting in 2006 and the European Cancer Congress in 2007. And this was published initially in GNCI in 2009 and updated in GNCI in 2015. And it is found that, and with a long-term follow-up, the laryngeal preservation was better in patients who received TPF compared to PF. And the laryngeal dysfunction-free survival was also better in patients who received TPF compared to PF. But there was no difference in overall survival, local region control, or disease-free survival in between the two arms. Okay, this is p-value was not significant. So in overall survival, local region control and disease-free survival were equal in the both arms. Now the question is there is a two school of thought. I told you to know this. The French group is trying a clinical trial. So it is one arm is to give concurrent chemoradiation plus or minus salvage surgery. The second arm is receiving, that is the using induction chemo, 3 cycles, TPF, then you reassess. Those who have 50% regression, then thus patients will receive radiotherapy. Those who did not have 50% regression will receive surgery followed by postoperative radiotherapy. And this is ongoing clinical trial. Now in larynx, certain group of patients may require induction chemotherapy, although there is no clear evidence, because patients who have airway compromise. So if you start this patient on a concurrent chemoradiation, there will be interruption of this patient, I'm not sure cartilage, so we have to check. Otherwise, so this patient, if this patient receives concurrent chemoradiation, this patient will require a tracheostomy immediately, or this patient initially itself may have stridor. So in this group of patients, if in order to have a facilitated concurrent chemoradiation, you need to give induction chemotherapy for these patients. Now coming to hypopharynx. Hypopharynx, if you look into the hypopharynx and larynx, they are very adjacent structures, but they behave entirely different. They are entirely different malignancies. And hypopharyngeal tumors may mainly present with advanced stage because symptoms are late, nutritional compromise, laryngeal preservation rates are poor, heavy nodal disease, and the response to chemoradiation is poor, so laryngeal preservation is poor, high chance for systemic failure, and relapse pattern is also more in the primary site as well as local relapse plus the systemic failure is more in hypopharynx. The main problem we face in hypopharyngeal tumors, we are not able to execute the planned treatment because of nutritional compromise. That's a real concern. So how to proceed further? So if you have a T3 pyriform sinus, so T3 pyriform sinus is characterized by 3 things. 1, if the size of the tumor is more than 4 centimeters. 2, if the patient is having a hemilarynx fixity. 3, the patient is having a cervical esophagus extension. So this is the right pyriform fossa. So this is the left pyriform fossa. So obliterated by a tumor infiltrating into the paraglottic pad up to the pre-epiglottic space, and also you can have the posterior pharyngeal wall is involved. But there is a plane. So this patient, if the size is more than 4 centimeters, hemilarynx is fixed, how to approach this problem? There are 2 approaches actually. One is to give induction chemo and assess the response based on the EORTC trial. So this is the EORTC trial. This is the stage 3 and stage 4 of patients with pyriform fossa. They're randomized to do surgery followed by postoperative radiotherapy, or you give 2 cycles of cisplatin 5-fluorouracil. Those patients who have a partial response were offered 1 more cycle of chemotherapy. And if the patient is in CR after 3 cycles of chemotherapy, we are offered radiotherapy. But the patient do not attain a PR after 2 cycles, we are offered, are considered as non-responders, were offered surgery followed by radiotherapy. So the concept is that the patient should attain a CR with induction chemotherapy, at least with 3 cycles. Then that patient should be offered radiation. If no CR with 3 cycles, patient should be offered surgery followed by postoperative radiotherapy. The patient should be properly counseled if you want to take this patient through this protocol. Because initially patient will have dysphagia. After 2 cycles, there is maybe PR will be there. So then you will give 1 more cycle. Patient may not have been CR. The patient will not be willing for undergoing surgery because there is a dramatic improvement in this patient. The patient should be offered radiotherapy. So that is the URTC trial. So to know this 50% regression is fine or not, then they have the GOTAC trial, which we have discussed earlier. So if you look into the URTC trial, now the trial which we discussed, the 3-year laryngeal preservation was 42%. The 5-year laryngeal preservation in the RTOG 9111 was 84%. It was double. So a 3-year laryngeal preservation in patients who achieve complete CR. And no, so what does it mean? It's a bad disease. Although they are attaining very good response with induction chemotherapy, the 3-year laryngeal preservation was only 42%. When they have done the long-term follow-up of this trial, and this was published in Annals of Oncology in 2012, with a median follow-up of 10 years. In patients who received induction chemotherapy, this is a dotted line, that is, it's induction chemo followed by reassessment, a response in CR, then you give radiation. The 10-year survival was 30%. And patients who received surgery followed by postoperative radiotherapy, this is 10%. So we are dealing with such a bad disease, hypothyroidism. So to know the concurrent chemoradiation, whether the concurrent chemoradiation is better or induction chemo is better, to know this group, so they have done a clinical trial. That is, this paper was published in ACTA on otolaryngology in 2010. This is by this was a T3N0 pyriform sinus tumor. Actually, it was started as a phase 3 trial, but the study was prematurely closed due to poor patient approval. Only 75 patients were recruited. So the patients were given PF 3 cycles and reassessment, the same regime. That is, you at least 50% regression. So those patients who received more than 50% regression were offered radiotherapy, and less than 50% regression were offered the postoperative surgery followed by postoperative radiotherapy. That was the one arm. The other arm was to give concurrent chemoradiation plus or minus salvage surgery. The laryngeal preservation was better in patients who received concurrent chemoradiation compared to induction chemotherapy, and this was statistically significant. The p-value was 0.016 compared to 92% versus 68%. This trial had a lot of pitfalls because the number of patients were less, and the study is not powered to answer this question. And when they looked into the overall survival and event-free survival, and where there is no difference in the outcomes, it was not significant. You can see that there's no difference between the 2 arms. So that is larynx and hypopharynx for organ preservation. The last question is that, is there any role for induction chemotherapy before surgery? Before that, I will discuss, this is the meta-analysis, McKenzie meta-analysis, a comprehensive analysis by tumor site published in Green Journal in 2011. If we look into the induction chemotherapy, you can see that the hypopharynx, the benefit was 5.3%. Larynx, it was 3.8%. And oropharynx is very low, 1.4%. And if you look into the concomitant, the magnitude of benefit was in oropharynx, it was 8.1%. In larynx, it was 5.4%. And in hypopharynx, it was 4%. If you indirectly compare, the induction chemotherapy may have an impact on hypopharynx because the high chance for a distant failure and also poor laryngeal preservation rates. Now coming to surgery. So those patients, so if you have a gingivobuccal complex tumor with a bone involvement, or patients who have tongue tumors, or patients with a larynx or hypopharynx with a cartilage destruction, generally they go for a surgery followed by planned postoperative radiotherapy. So this is a gingivobuccal complex tumor with a bone involvement, with a skin involvement, and the patient with a cartilage destruction. So this is a 64-year-old gentleman, PS1. Patient had a cartilage destruction. You can see the thyroid cartilage is destroyed, strap muscles are involved, as you can and also abutting the thyroid gland. It's involving, the patient is having a subglottic extension is also present. So in this group of patients in CT, you need to check few things. One, what about the thyroid gland? What about the cartilage destruction? The other is whether the patient is having a post-cricoid involvement. What about the vessels? Whether vessels are intact. What about the skin? Whether we need a extensive reconstruction for this patient. All these patients should do a surgery, total laryngectomy, followed by a bilateral neck dissection, and patient require voice rehabilitation, immediate or delayed, followed by post-operative radiotherapy. So all these patients require planned surgery followed by post-op radiation. So in oral cancer, is there a role for induction chemotherapy in operable disease? This is a paper by Lisa, initially published in JCO in 2003, updated in Annals of Oncology in 2014. The patients were randomized to do surgery followed by post-op radiation or 3 cycles of PF followed by surgery post-op radiation. There is no benefit in terms of overall survival or local control. But there's a reduction in the rates of mandibular resection from 52% to 31%. So there was a reduction was there. And the data was updated in Annals of Oncology in 2014. Either in terms of overall survival or local control, there is no difference. Again, you can see that if you give induction chemotherapy, 3 cycles of PF, in operable oral cancer, there is no difference in terms of local control or overall survival. Now, the same question was asked in a Chinese paper, which was published in JCO in 2012. And they used 2 cycles of cisplatin 5-fluorouracil and docetaxel, the standard TPF. The 2 cycles, surgery followed by post-op radiation, or 2 cycles of TPF followed by surgery and post-op radiation, stage 3 and stage 4 oral cancer. The data was published in JCO in 2012 with a median follow-up of 30 months. There is no difference in overall survival or disease-free survival. The p-value was not significant in terms of either overall survival or disease-free survival. So there is no benefit of giving a TPF 2 cycles for standard surgery followed by post-operative radiotherapy. There is no data comparing PF versus TPF before surgery and followed by post-operative radiotherapy. So incorporating these 2 trials, they have done a meta-analysis which was published in European Journal of Cancer in 2015. Again, there is no benefit. Now, what is the role of induction chemotherapy in inoperable CA oral cavity? There is no prospective data. This is a paper from Tata Memorial Hospital by G. Patel. This is published in 2014. In Oral Oncology. It is a retrospective analysis of 721 patients. Those patients who received induction chemotherapy, there was a conversion of 43%. Subsequently, they underwent surgery followed by post-operative radiotherapy. The median survival of this paper, this whole group, that is inoperable locally advanced disease. So these are 10.8%. The median survival in patients who received surgery was 19.6 months. In patients who did not undergo surgery, it was around 9 months. So now the question is, I'm coming to the last part of my talk. This is there a role for immunotherapy, which is a hot cake? So is there a role for induction in immunotherapy as an induction agent? So neoadjuvant nivolumab and pembrolizumab is being evaluated before surgery in the Keynote 681 and IM star head and neck trial. So these are all ongoing clinical trials. We do not have any data to say that there is a role for immunotherapy in the induction setting. So now coming to the last slide of my talk. Okay, in early disease, it is radiotherapy or surgery. No role for systemic therapy. Concurrent chemoradiation remains the standard in patients who are considered for radiotherapy as the definitive treatment. Induction chemotherapy has a role in hypothyroidism. Okay, to know further, the induction versus concurrent is ongoing by the front. It's ongoing clinical trial. I have discussed. Is there any benefit by giving a chemotherapy prior to concurrent chemoradiation? There is no benefit. You may give if there is airway compromise because you enter a disease, or if there is a delay in starting radiation, or due to logistic reasons. If you want to give induction chemotherapy, 3 drugs is better than 2 drugs in terms of overall survival and progression-free survival compared this based on facts 3-3 and 3-3. No benefit for induction chemotherapy in operable disease. There is no data to give induction chemotherapy in operable disease, but this has to be individualized. If you feel that this is a borderline operable disease, then you can say induction chemotherapy. But you feel that the induction, if you give induction chemotherapy, then generally you have to presume that this patient should undergo surgery. If you give, is there a role for adjuvant chemotherapy? There's no role for adjuvant chemotherapy. So that's all about the chemotherapy in locally advanced head and neck cancer. I've not discussed about the anti-EGFR therapy, which because we have discussed this in the same platform earlier. So I have just concentrated only on the chemotherapy part. We have not discussed about the role of immunotherapy in locally advanced disease, along with definitive radiotherapy. There is a trial called Javelin trial, which was very recently published in last ESMO meeting, which was presented. And it was published in April in Lancet Oncology. Shows that if you add avelumab in addition to concurrent chemoradiation, there is no benefit. So it is a negative trial. So thank you very much for your patient listening. Okay, I'm ready to take few questions.
Thank you, sir, for such a nice lecture. We have got a lot of information and very thankful for that. And I request participant to put questions in chat box.
Okay. Yes. Okay, I will take up that. Chat box. Yes. Join. Okay. Concurrent. Okay. I'm waiting for the questions. Okay. If no questions, then shall we wind up? Okay. If anyone is interested to have the slides, just email me. I'm happy to share my slides. I consider this as a public property. Okay, so if you want anyone, if you want to have anyone want to have any of the articles which I've discussed, I'm also happy to share that. As it is, as a long-term benefits for NACT. Okay, that's a very good question. Okay, if you look into the long-term results of the RTOG 9111, the induction chemotherapy had a non-significant benefit in terms of overall survival because there were unexplained deaths in patients who received concurrent chemoradiation. That is the author's explanation. And but this data, we have to bear in mind there are a lot of propaganda for induction chemotherapy, but this was not statistically significant. There's no difference. So 3 arms, if you look at 10-year results published in JCO in March 2013, there is no difference in survival between the 3 arms. The induction chemo followed by radiotherapy or concurrent chemoradiation or radiation alone, there is no difference in survival. Rationale of giving induction chemotherapy in N3 disease, again, there is no clear data. So if you look into even in N3 disease, if you look into the NCCN guidelines, latest NCCN guidelines, there is no data. I didn't say that it should be given for N3 disease. You may give in patients who have N3 disease. Okay, I didn't say that there is evidence. There is no evidence. The rationale is, there are different rationales. One, N3 disease are likely to have issues in the subsequent chemo radiation program. Okay, so if you can adopt, especially if the patient is undergoing an IGRT, then if you adopt, then you do an adoptive IGRT rather than doing an adoptive IGRT. That's one logistic reason. Second rationale is that these patients can have high systemic failure. And if you have any delay in starting the treatment, so these are concerns of start giving induction chemotherapy. I didn't say that induction chemotherapy should be given for N3 disease, but if you want to ask me which are the group of patients you may consider induction chemotherapy, as the patients who have airway compromise, patients who have N3 disease, patients who have a delay in stimulation, these are the group of patients. Okay, what is the maximum number of cycles of induction chemotherapy in hyperpharynx? Is it 2 or 3? So the trials which evaluate the role of induction chemotherapy in hyperpharynx are 2. One is the URTC trial. They used 3 cycles of PF. In patients who had CR with 2 cycles were given 1 more cycle of PF, then the patient was given radiotherapy. If you look into the GOTAC trial, 2001 clinical trial published in GNCI in 2009, it again showed this, you give 3 cycles of PF. So the rationale of giving hyperpharynx, the nerve cycles may be increased. Yeah, your mail ID. Okay, okay, I will type my mail ID. Sorry, I closed my this one. Okay, I have sent my email ID in the chat box. So shall we wind up?
Yes, sir. Sir, one last question. In starting, you have said that induction chemotherapy followed by radiotherapy, there is a lack of local synergy.
Yeah, yeah.
What does it mean, sir?
So concurrent chemoradiation, the synergy means the patient is given the concurrent radiation and chemotherapy together. No, so
Yes.
all the benefits of concurrent chemoradiation. So there is another question: role of NACT in oral cavity and any evidence, sir. Okay. So I have discussed this oral cavity. There are 2 clinical trials, and there is a meta-analysis. One paper, the first paper was from the JCO in 2003 by Lisa Lesitra, updated in GNCI in Annals of Oncology in 2014. No benefit. So the rationale of giving induction chemotherapy in oral cancer, although there is no evidence, rationale is if you can give induction chemo in oral cancer, these patients are generally treated by especially tongue tumors, especially if you cannot make out the posterior extent properly. You can translate that R1, R2, or R0, R1 resection to an R0 resection. That's number 1. Number 2, those patients have, if you give induction chemotherapy, the extent of resection can be reduced. Third thing, it can lead on to a better functional outcome. Fourth thing is that if you can remove, sometimes you have to do a segmental resection of the mandible or to have an en bloc removal of the tumor. If you can give induction chemotherapy, then some proportion of patients may be able to undergo a primary closure. Other rationale is you can avoid some flaps. So if you have the vascular flaps, the role of flaps may come down if you many of a substantial number of patients undergo a primary closure after induction chemotherapy. So this is a rationale of giving induction chemotherapy. My chat, your mail ID is not showing in chat box. Okay, it is given in the chat. Okay, 1 minute. Okay, I will type once again. Anyone can see my email ID in the chat box? Because
it's not visible.
I have typed again. Okay. Yes. Okay, sir. Good evening. Greetings from RCC Raipur. Have you tried taxane cisplatin as concurrent CTRT setting? Okay. If you do so, what is the dose of docetaxel and cisplatin? Okay, that's a very good question. We look into the McKenzie meta-analysis. Comparing, I didn't discuss this problem because it is mainly an induction chemotherapy discussion. So if you look into the McKenzie meta-analysis, which is published in 2009 in Green Journal, updated in the same journal in 2021, the polychemotherapy basis monochemotherapy, in terms of overall survival, there is no difference. This p-value is not significant. That is the reason why you give single agent cisplatin along with radiation. So there is no data to give a polychemotherapy is superior to monochemotherapy in along with radiation in locally advanced head and neck cancer. The second observation of the meta-analysis was that if you give a platinum based a non-platinum, the platinum had a better outcome, and the hazard ratio of death was in cisplatin in patients who received radiotherapy was 0.74, and there is a 26% relative reduction in death. So there is no data. There are some group use 2 drugs. If you look into the French group, they use carboplatin plus 5-fluorouracil along with radiotherapy. I agree that. But there is no hardcore data to say that a polychemotherapy works better than a monotherapy along with radiation. So how to choose between paclitaxel and docetaxel? Okay, how to choose between paclitaxel and docetaxel in the induction setting? Suppose if you want to use a 3-drug regimen, okay? What's my practice is a 3-drug regimen. In a patient who have, say, inoperable or borderline disease, you are planning for it make it operable. Or a patient who have an N3 node, if a patient and you very bulky primary disease, okay, individualize. You have to individualize in such situations. Generally, we use in patients who have advanced tongue tumors or gingivobuccal complex tumors, where advanced disease with a masticator space involvement. In such group of patients, and I usually do not use free drug above 60 years, to be very frank with you. Okay, so free drug performance status 1, good renal function, highly educated patient who can understand the whole scenario. The patient will respond to the hospital at right time if there is any febrile neutropenia or a diarrhea occurs. And the patient should be able to understand the whole situation. And patient is a well-built patient. In such patients, you give free drug. We use this tax 3-2-3 regime. That is a 75, 75, 75. To be very honest with you, we do not use 5 days. We use 4 days. Cisplatin 75 milligram per meter square, docetaxel 75 milligram per meter square, and 5-fluorouracil 750 as continuous infusion for 4 days. So this is the regime we use. We generally do not use paclitaxel because that's a Spanish group. They have used paclitaxel 175 milligram per meter square along with cisplatin and 5-fluorouracil. We are not using that. Okay, I know that paclitaxel is a better tolerated drug. Very compliance is better, but in this group of patients, we are using more data is with docetaxel, so we generally use a docetaxel compared to paclitaxel. Okay, would you capcitab as an alternative to 5-FE in free drug regime? No, we use F5-fluorouracil. Okay, so whether my mail ID is there in the chat box?
Oh, sir, it's not visible till now.
My God. Okay, it is how to choose between direct message to medical oncology. I don't know what is the problem. Okay, so it is Dr. Cessal Thomas, Dr. Cessal CSSAL Thomas 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 @gmail.com. Okay. Okay, I will do one thing. I will share once again. Okay, then in my I will show that. I'm sure now it is visible. Okay.
Yes, sir.
Yeah. So thank you very much for your cooperation. Okay.
Thank you, sir. Thank you, sir. It was a very nice lecture, very informative, mesmerizing lecture. Thank you very much on the behalf of forum, and we will get more lectures from you in future. And now we can end, sir, since there is no question, no more question.
Okay. Good night. Okay.
Good night, sir. Thank you, sir. Thank you, everyone.